Hello, I am Apoorva Chandar and I am one of the co-first authors for our study Wide Area Transepithelial Sampling for Dysplasia Detection in Barrett's Esophagus, a systematic review and meta-analysis. Barrett's esophagus is the only known precursor lesion for esophageal adenocarcinoma, a cancer which carries a dismal prognosis with a 5-year survival less than 20%. Barrett's esophagus is believed to progress through a metaplasia, dysplasia, carcinoma sequence, and as such, early detection of Barrett's esophagus and continued surveillance has been shown to have a survival benefit. In our previous work, we have shown through a meta-analysis that receipt of surveillance is associated with an improved survival and decreased cancer-related morbidity from early-stage detection. Regular, guideline-directed surveillance, when complemented by modern endoscopic eradication therapies such as EMR, ESD, and radiofrequency ablation, has been shown to be associated with lower rates of progression to cancer. Surveillance in Barrett's esophagus is accomplished by strict adherence to the Seattle protocol, wherein random biopsies are obtained in 4 quadrants every 1 to 2 centimeters in the Barrett segment. However, this time-honored tradition of the Seattle protocol, despite its rigorous nature, has been shown to be associated with poor adherence, with adherence decreasing as the length of the metaplastic segment increases. It is therefore not surprising that up to a third of adenocarcinoma patients have missed dysplasia, that is, a previously negative surveillance endoscopic evaluation within 1 year of a cancer or high-grade dysplasia diagnosis. Wide area transepithelial sampling with 3-dimension analysis, which we will call WATS 3D throughout the rest of this video, is a novel technique in which an abrasive brush is used through the endoscope to scrape and sample the entire length and breadth of the visible segments of the Barrett's esophagus. These samples are then analyzed by a proprietary neural network assisted 3-dimensional computer algorithm, and areas of abnormality such as abnormal glands, cells, or cell clusters are highlighted and displayed to a reading pathologist. The major advantage of WATS 3D is that it allows a significantly larger area of Barrett's esophagus to be sampled, potentially avoiding the risk of sampling error. Now, why did we feel that this study needed to be done? There are several studies that have demonstrated the efficacy of WATS 3D in community and tertiary care settings for both Barrett's screening and surveillance. And WATS 3D was recently included in an ASG guideline for Barrett's management. However, it is unclear what proportion of dysplasia specifically is picked up by this technique, and furthermore, whether results are confirmed by traditional forceps biopsies. More explicitly, does a WATS 3D diagnosis of dysplasia carry the same risk of progression as dysplasia seen on biopsies obtained by traditional forceps? The importance of this question arises due to the fact that endoscopic therapy decisions may need to be made based on these samples. But before initiating endoscopic eradication therapy, which has its own inherent risks, we need to be certain that we will be preventing dysplasia and cancer progression. We therefore conducted a systematic review and meta-analysis to assess the rate of dysplasia diagnosis based on WATS 3D sampling and to assess the confirmation of dysplasia on forceps biopsies.
Hello, I am Chamil Kodapilli, and I am the other co-first author for our study. So what did we add to the existing knowledge? After a rigorous search, we identified 7 studies for inclusion in our meta-analysis. This included just over 3,200 patients diagnosed with Barrett's esophagus based on forceps biopsies. Through our meta-analysis, we have demonstrated that the addition of WATS 3D provides an incremental yield of 7.2% new cases of dysplasia, that is, those not detected by traditional forceps biopsies. We further assessed outcomes specifically for high-grade dysplasia and adenocarcinoma, and WATS 3D resulted in an incremental yield of 2.1% over that identified by forceps biopsies. Regarding reconfirmation of WATS 3D results, only 2 studies reported this outcome. In one study, of 9 patients in whom this information was available, 4 were confirmed with high-grade dysplasia, 3 had low-grade dysplasia, and 2 had no dysplasia. In the other study, follow-up of up to 18 months showed reconfirmation of dysplasia in 5 of 11 patients. We also conducted a sensitivity analysis excluding indefinite for dysplasia from the outcome pool, and in this analysis, Watch3D added an incremental yield of 7.3%, mirroring the overall dysplasia incremental yield. Unfortunately, no study reported progression rates to high-grade dysplasia or cancer, nor assessed mortality outcomes, though we did identify one study in abstract form that reported a progression rate of 0.33% per patient year in patients with non-dysplastic or low-grade dysplastic Watch3D diagnoses. It should be noted that almost all Watch3D pathology has been interpreted by a small, select group of Watch-trained pathologists. Little is known about the proprietary nature of the Watch3D system, other than the fact that it uses a neural network-based computer algorithm to perform a three-dimensional analysis of abnormal cells and automatically flags 80 of these most suspicious images for further interpretation by Watch3D pathologists. In only one study were the Watch3D only positive dysplastic samples reviewed by 2 external pathologists. In addition to the above, a large proportion of the dysplasia detected by Watch3D was classified as crypt dysplasia. Up to now, the significance of crypt dysplasia in and of itself has been somewhat controversial, as some amount of baseline atypia is invariably found in basally located glands in a Barrett segment. Unlike traditional forceps biopsies, where one is interpreting dysplasia in the context of a larger biopsy surface area showing more cellular architecture such as the lamina propria and muscularis mucosa, the absence of these architectural features in Watch3D brushings could lead to the possible overdiagnosis of dysplastic Barretts. The other possibility is that the operators could be accidentally brushing the cardia, and Watch3D might have picked up intestinal metaplasia of the cardia and not necessarily from the visible Barrett segment or tubular esophagus. So what are the next steps? Overall, this study adds to the breadth of knowledge regarding Watch3D outcomes. We demonstrated dysplasia diagnosis is increased by approximately 7%, and high-grade dysplasia and cancer diagnoses are increased by 2% with the addition of Watch3D. It is important to note that in 4 studies where this information was available, 62.5% of forceps biopsies with dysplasia were found to be non-dysplastic with Watch3D. This signifies the importance of Watch3D as an adjunct and not replacement to the traditional surveillance protocol with forceps biopsies. The next steps for Watch3D includes elucidating long-term progression rates and reconfirmation of Watch3D samples by forceps biopsies. Thank you.